So here we go. When we're looking at images, you want to make sure that the joint congruity is normal. You're looking for, these are bones that have to slide over each other. One of the tricks in the wrist is to use the arcs of Galula that kind of show you how smooth those surfaces should be in the relative alignment. These joint spaces should all be about the same in terms of distances. When they're not lined up, you have something like this, where you can see the arcs of Galula are disrupted, and you look on the lateral radiograph, you can see that the capitate is no longer aligned with the lunate. So this would be a perilunate dislocation. In addition, if you look at the proximal arc of Galula, you can see that the scaphoid is disrupted. You have a transscaphoid fracture as well, and it's not unusual for there to be more than one injury when you're looking at trauma films. So always look for the second one. There's the perilunate dislocation. The joint spaces should all be about the same. So in this case, obviously the distance between the scaphoid and lunate is much bigger than the distance between the other carpal bones in the scapholunate dissociation. Now when this occurs, the end result will be what's called a slack wrist or scapholunate advanced collapse, which is radial-sided arthritis, which is why you want to treat this. You don't want this to go unnoticed. You want to prevent the arthritis that will end up being a lifelong problem if you don't treat it. There's also a little avulsion fracture off of the scaphoid fracture in this. Some of the signs that we associate with this injury are the ring sign. The ring sign, where you can see that the scaphoid kind of looks like a high school ring with the distal pole making the gemstone and the other part making the band. And then also the widening of the space is usually referred to as a Terry Thomas sign, or the particular Michael Strahan sign, whoever's your favorite gap-toothed person. When we're looking at radiographs, we often get 3 views, and the reason is that something is often invisible except on just one view. So you want orthogonal views and then usually in the oblique. Here's a case where you can't see anything wrong, but you get the lateral view and you can see there are a couple of bone chips off of the triquetrum. A really, really common fracture, and if you don't look at every wrist for this, you're gonna miss it. This is my favorite fracture. Now remember, the difference between a great call and a subtle finding is whether it was you or your colleague that missed it. And so this is a fracture I find gets missed a lot. You look very, very carefully right here. Look at every wrist for this fracture. You will see a lot of fractures that a lot of people will miss if you look right there. It's a real common fracture right at the ulnar side of the distal radius, and often it's just a hairline radiolucent line. If you look carefully on this one, you will also see another one of those fractures. Right here. And right there. Look for that fracture every time you look at a wrist for a fall on outstretched hand. You will find them and you will be a hero. Other findings that we can use, secondary findings, are soft tissue swelling. So look at your lateral radiographs for the soft tissue swelling. Look where it is. Is it over the metacarpals? Is it over the distal radius? Also look at the pronator fat pad, which is right here. There's usually a nice straight black line here, the pronator quadratus fat pad. And if it's gone or bowed, that's a suggestion that there's something wrong there, edema or hemorrhage. And there may be an occult fracture, usually distal radius, perhaps the scaphoid. But that's a good sign to look, to clue you in that there's something wrong, and don't just blow it off. There should always be a fat pad there. Here is another one. This one is bowed. It's supposed to be a straight line. Sometimes fractures, you don't see the fracture line. All you see is a buckling of the cortex. One classic place is right here, the distal radius. Sometimes it's hard to distinguish this from Lister's tubercle, but look for a buckled cortex. That's the compression side of the injury. Usually people fall on their palms because they protect themselves, and they may buckle the cortex, and you might not see the volar-sided tension injury. So look for the buckle fracture. This bowed pronator quadratus fat pad is a clue that there's something wrong, and that's what's wrong. When we turn the elbow, in kids, this is really, really useful, looking for the fat pads. And all you need is one. You can have the sail sign anteriorly, like a sailboat sail, or you can have a posterior fat pad, which is normally this is a shallow, the fat in here is right up against this cortex in that fossa between the condyles. And when you have a hemorrhage, it'll push that fat out into view. You usually see fat here anteriorly in a normal patient, but it's at a very shallow angle with respect to the long axis of the humerus. When it's pushed up, it'll form a sail. It'll come out at like a 40-degree angle instead of like a 15-degree angle relative to the bone. But all you need is one. When you see it, look for what's wrong. Normally the capitellum is bisected by the line that is along the anterior surface of the humerus. That's called the anterior humeral line. If it's not bisected, that's a clue that the reason you have a joint effusion is because of a supracondylar fracture. So look for that. Now, I kind of, in my simple way, I like to just look at the humeral ossification centers in the pediatric elbow. And I have this, this is a combination of different things. One's called Nelson's X, and the other one is a mnemonic, CITE. C is the capitellum, I is the internal epicondyle or medial epicondyle, T is the trochlea, and E is the external epicondyle. That's roughly the order in which you see them, and they usually occur somewhere around 1, 7, 10, 11. Now those are really crude numbers, but it gives you the order in which you see them. And that's very helpful in distinguishing a number of injuries in the elbow, in the pediatric elbow. So CITE, 1, 7, 10, 11. And you go from C to I and T to E in a cross. That's called Nelson's X. How do we use that? Well, capitellum, age 1. Then the next one should be 7, which would be the internal epicondyle. There should be something here. Trochlea would be 10. So if this is the trochlea, it's a 10, and they might not be old enough to have 11. So we have 1, but there's no 7, and we have 10. Well, we've skipped 7, that's not right. So where is 7? Well, there. It's a epicondyle, medial epicondyle avulsion and dislocated near the joint. So that's how you use this system to sort out these ossification centers and the different avulsions that you could have. This is a horribly photoshopped series of images, and because I don't have them all, but it illustrates the point. There are a lot of things that can happen in pediatric elbow. Using our numbering system, 1, 7, 10, 11, this child is not old enough to have 7, 10, or 11. They only have the capitellum. So the radius is lined up with the capitellum, the radius is lined up with the ulna, the capitellum's lined up with the humerus and capitellum are lined up with the radius and ulna. So everything's lined up on this image. Now, we have a number of things that could happen. One, if we draw the radiocapitellar line, which the radius should always line up with the capitellum no matter how you take the x-ray, and we do this, the radius is no longer lined up with the capitellum. So where is the problem? Between the radius and the capitellum. So what is that? A radial dislocation. Nursemaid's elbow. Okay, so the radiocapitellar is not lined up. How about this one? Capitellum's not lined up with the humerus, but everything else is kind of lined up. How would you get this? A Salter 3 fracture through the epiphysis. Remember, the trochlea and the capitellum are part of the epiphysis. And so by having the capitellum removed from the humerus, this would be a Salter 3 fracture. This is what happened. Radius and ulna are not lined up with the humerus. Well, this is an elbow dislocation. But if we do our 1, 7, 10, 11, we go 1, 7, 10, it's not oriented right, and not old enough to have 11. So 1, 7, we're missing 7, and we have a 10 that looks weird. Well, they're not old enough to have a 10. That actually is the 7. That's the medial epicondyle that got taken with the radius and ulna when the elbow dislocated. So that's how we got that. A lot of bones you can look at as ring structures. You have a compression side, you have a tension side. You have, when you break one side of the ring, there's something wrong with the other side of the ring. The radius and ulna form a ring. We use them in mnemonic, Mugger, Montesia, ulna fracture, Galeazzi, radius fracture. So the Montesia ulna fracture is associated with a radial dislocation. The two parts of the ring. At the other end of the forearm, we have an ulnar dislocation, but a radius fracture. So that would be the Galeazzi combination. So always, this is the one that is going to be hard for you. Always look for that ulnar dislocation when you have a distal radius diaphyseal fracture. Here is what it looks like on an AP radiograph. The ulna is dislocated. Like I said, all you need is one fat pad. Here is a patient with the Sale sign. This fat right here should actually have a contour that goes like this and go all the way to the bone. And instead, this edge got lifted up from a hemorrhage, got pushed up out of this coronoid fossa. We don't have a posterior fat pad in this one. So we have a joint effusion, we have to know why. If it's trauma, look for something. So one of the things you might do is do a dedicated radial head view. And on all the other views, you didn't see it on this patient, but on this view you did. So there's a radial head fracture. So when you see an effusion, find out why. Get more pictures. Here's a CT scan just showing that. Here's another one, posterior fat pad, Sale sign. This is a place you always should look. Right here, this is the coronoid process, and there's a little avulsion, a real common fracture, and it's easy to overlook. It may be only visible in this lateral radiograph. So look here, make it a point to look here on every elbow radiograph for these little avulsions off of the coronoid process. It may be a sign that the patient may be dislocated or, and then was reduced. Here is the AP radiograph, I can't see it. Okay, shoulder dislocations. The anterior shoulder dislocation clinically usually is pretty easy. What we're charged with is usually trying to find the fractures that are associated with it. There are two that are important that we talk about. One is the Hill-Sachs deformity. The reason this is important is if it's deep enough, the patient will have what's called an engaging lesion. And with just minimal movement of their shoulder, they will dislocate again. And they have what's called a positive apprehension sign. They say, oh no, I can't move my shoulder any more than that, I might dislocate. They know that it's going to happen. And so if it's a deep trough, it will just catch and then force the shoulder out with just another degree of movement. So the Hill-Sachs deformity, this is a 45-45 view showing it. This is an MR. On the MR images of the shoulder, the top two images of the humerus should always be perfectly round. Below that, you're going to start getting into the greater tuberosity and the trough between the greater tuberosity and the humeral head. But this is not perfectly round. This is a Hill-Sachs deformity, and it's going to be in the posterolateral corner. There is a dedicated plain film view called the Stryker view that you could get if someone wants a plain film verification of a Hill-Sachs deformity, though most of the time we're doing CT scans in complicated cases where the surgeon wants to know the geography of the fractures. This contour should be a nice smooth curve. It shouldn't change abruptly. So this is a very shallow Hill-Sachs deformity. The other thing that you're going to be looking for is a Bankart lesion, a little chip off of the anterior inferior glenoid rim. Sometimes it's not so little. And often you'll do a CT scan to quantify how big it is, because that will help the surgeons decide what kind of surgery they're going to be doing to fix it. Bankart. Sometimes the Bankart lesion is not bone, sometimes it's just labrum. This is an example of a labral tear called a Bankart tear, where the labrum is completely detached from the bone. This is an A-bear view with, and when you do A-bear views, this is one of the views of the shoulder you want to do at the end of the exam because it's painful. And the patient, if you do this first, you won't get any more images. So do this at the very end of the exam. It can be very uncomfortable. Posterior dislocation, sometimes they're real easy. This is a transscapular Y view with a posterior dislocation. But a lot of times they're missed because the humerus doesn't go down or up, it goes straight back. And so what can keep you from missing this is doing what's called a 45-45 view, where the patient doesn't have to move their shoulder. They can keep their arm in the position that it's in, and you angle the beam down at a 45-degree angle with respect to the table, and you have the patient tilted 45 degrees. And that gives you some anterior-posterior information, and you'll never miss a posterior dislocation if you use this view. So this is a 45-45 view. This is antero-inferior, this is postero-superior, and the humeral head is obviously dislocated posteriorly relative to the glenoid rim. The way I know it's anterior is here's a coracoid. Here's another posterior dislocated shoulder, but you can see there's really not a lot of vertical malalignment. It's a little bit up, but not too bad. But it's indented here. And so you can have what's called a reverse Hill-Sachs, sometimes called a trough sign. It's this indentation in the anteromedial cortex of the humerus because it impacted the posterolateral glenoid rim when it dislocated posteriorly. Here's another example of the trough sign. And that's an MR showing it. There are AC separations, first degree, second degree, third degree, fourth degree, fifth degree, sixth degree. There are 6 degrees of separation. Kevin Bacon has absolutely nothing to do with this. The first degree is it just hurts. The second degree, you've disrupted the acromioclavicular ligaments. The third degree, you've disrupted the coracoclavicular ligaments. You might have to do weight-bearing views with comparison to the contralateral side to sort out a second from a third degree separation, or in difficult cases where you're not sure if it is an AC separation at all. You do comparisons with the contralateral side and look for differences. The normal is about 3 to 5 millimeters between the acromion and the clavicle. And you want to look for a difference no more than 5 from the contralateral side with this. The most reliable measurement, if you're going to do this measurement, is from the top of the coracoid process to the top of the clavicle. This distance isn't as reliable or reproducible. So this is how you want to do that measurement and look at the difference between the two sides. Stress fractures. We had one just today. 3 weeks ago, a patient came in, totally normal foot. Now still has pain. We saw this. This isn't that patient, but we saw exactly the same thing, a stress fracture. Usually it takes a while. The first thing that happens is a stress fracture, or in the development of a stress fracture, is the osteoclasts come in and take out the bone in response to the new mechanical stresses that are being applied to that bone. Later on, the population shifts to the osteoblasts who start laying down new bone. So it may be 4 or 5 weeks before you see periosteal reaction. And you might never see the lucency from the osteoclastic response because you need to lose about 50% of your mineralization to see that kind of activity. So you might miss it. So it's not unusual for a stress fracture to be initially negative. Other tests you could do are nuclear scintigraphy or MRI to sort this out if they have pain. Metatarsal fractures, fifth metatarsal fractures, there are a couple different varieties of this. They get treated differently. And you'll get a call from the emergency room saying, oh, is this an avulsion injury, or is this a Jones fracture, or is this a dancer's fracture? And the best thing to do is describe the anatomy, because there's a lot of confusion out in the clinical world on what to call these things. This one is an avulsion of the apophysis, so it's very proximal pole of the fifth metatarsal. This one, person is allowed to walk on with a cast or a walking boot. This one is a Jones fracture. It occurs at the junction of the metaphysis with the diaphysis. This one, you're put on crutches. The reason is because you are more likely to go on to a non-union with this than you are with the avulsion injury. And then a fracture in the diaphysis may actually be treated with pins. So just describe the anatomy and rather than use the cute names. When you're looking at the Lisfranc joint, a couple things. These bones should perfectly align. So the second metatarsal should perfectly align with the central cuneiform or second cuneiform. On the dorsal, on the lateral radiograph, the metatarsals should never, ever be dorsal to their respective cuneiforms. If they are, there's something wrong. If you have doubt, if they say they have midfoot pain, we think there's something going on there, get weight-bearing views with the contralateral foot and look at the differences. Often you have to go to that. This is a real common injury that's commonly missed unless you go to the weight-bearing views. So if they have midfoot pain in a traumatic injury, get the weight-bearing views. If you get a CT scan, sometimes you'll be shocked at how many other little bone fractures there are in this region when you've got this injury. So that's the Lisfranc injury. Sometimes there's an os in between these two called the os intermetatarsalis, which is normal. The way you tell that from a fracture there is look at the quality of the bone. If it's rounded, looking like it was a pebble rounded in the stream, then it's probably an os. The other thing would be get the contralateral foot and just do the weight bearing to see if there's a discrepancy in the spaces between the bones in that region. That's my special effect. Another common fracture that is commonly missed, you should look at this space, at this place for every single ankle radiograph, is right here. The anterior process of the calcaneus, the bifurcate ligament attaches to that, and that can be, that is often broken with the same mechanism as an ankle sprain. This is a commonly missed fracture. Make a specific effort to look for it. I'd like to say a few things about ankle injuries. I find that for myself, I like using the Lauge-Hansen system, which is kind of the first word is the position of the foot. The second word is the movement at the time of the injury. So the first word is pronation or supination. The second word is external rotation or adduction or abduction. This is a pronation, external rotation. If you're trying to think of what's going on with this, I'm going to show you a little pseudo video here. Pronation is the position of the foot when you're stepping off of your big toe. Supination is when you're kind of landing on your foot just after heel strike and you're kind of putting your weight onto the fifth metatarsal. So that's the position of the foot at the time of the injury. So this is a pronation. This person injured this while the foot was pronated. We have way too wide a gap here. There should be less than 4.5 millimeters. So they disrupted their deltoid ligament. Whenever you see something wrong with the medial side of the foot, look for something on the fibular side. Look for disruption of the syndesmotic ligament with too wide a space here. There should be 5.5 millimeters. And then here's my little video showing you how this happens. So this is a 4-stage process. The first thing that happens is the medial malleolus gets pulled off. The next thing that happens is you start splitting the anterior syndesmotic ligament, and that may go all the way up to the fibular neck and the interosseous membrane. And then if you keep spinning, you tear off the posterior malleolus as well. So when you see number 4, and you saw number 1, what happened to 3? Well, you shoot the knee. Get an image of the knee, and sure enough, there's the Mason-Neuve injury. So that's how you use this. I like to use the system because it allows me to predict where the other injuries are. Another thing that happens with ankle injuries is sometimes you shear off the talar dome. Here's a person with an old avulsion of the fibula, but you look here and you have an osteochondral defect of the talar dome. Sometimes this is from repetitive mechanical stress. Sometimes it's an acute injury that leads up to it, an ankle sprain. This is an MRI showing the edema. Avulsion injuries may not show you much edema. Compression injuries usually show you edema if they're relatively acute or subacute. With the osteochondral defects of the talar dome, there tends to be there is a tendency for the bone fragment to actually flip upside down. So this is an important injury for you to look for whenever you're looking at ankles. In kids, they have some unique things that go on. Here's a child that's had an injury, and because they close here before they close here, sometimes you get this fracture, which is called a juvenile Talot fracture. Look for this in all your ankle injury films on kids, especially around the age of 10, 11, 12 years old. They may avulse off that postero lateral corner of the tibia. It's called a juvenile Talot fracture. Sometimes the patient will say, oh, my knee dislocated or something like that, and you'll look at them and the patella is totally normal in position on the plain films. But if they may come in for an MRI because they still have knee pain, look for the bone edema on the medial aspect of the patella and the bone edema on the lateral femoral condyle. And when you see those two things, they go together. That may very well be the result of transient patellar dislocation. And you look at then of course you're going to look at the medial retinaculum and the vastus medialis obliquus to see if there's been, how much of an injury there is. And there usually would be one if you've got bone contusions in these locations. When you're looking at knee radiographs, pay particular attention to posterolateral corner and the lateral aspect of the tibia. Sometimes you'll see this little sliver. This is an avulsion injury off of the lateral cortex of the tibia. And sometimes you'll see an avulsion off of the fibula. When you see this, it's often associated with this, an ACL tear. So the Sagond lesion is often associated with an ACL tear, and when you see that little tiny bone chip, don't blow it off. Say, oh, in that location, that's associated with an ACL tear, and then let the clinician know, they may have ligamentous disruption. Whenever you look at a lateral radiograph of the knee in the setting of trauma, look for a fat fluid level, a straight line right there. Something is broken. We don't know what. When you see that, something is broken. And then get more studies, either a CT scan or obliques, your preference. This case, can't see much, but there's too much sclerosis right here. And that's a sign that there was a posterior lateral tibial plateau, a lateral tibial plateau fracture. Really, you don't see any real cortical interruption. You just see too much sclerosis. But you're clued to that because of the fat fluid level. You know there's something wrong when you see that. The Schatzker system is one of the things our orthopedists like to use for describing tibial plateau fractures. This is a Schatzker 4. It's in your syllabus, the different types, but this basically usually starts just lateral to the tibial eminence and goes medially. The Schatzker system is based on prognosis. 1 through 3 are lateral, and then 4 is a medial, and then 5 is medial and lateral, and then 6, it's so discombobulated that there's no connection between the diaphysis and the tibial plateau. 4 is worse because you tend to bear more weight on the medial side and you lose the reduction. So that's why it tends to be worse than the lateral ones. Here, cross-table lateral showing a joint effusion. In the setting of trauma, when I see a large joint effusion, even without fat fluid level, I'm looking very carefully to see if there's another fracture, and I'm more often than not inclined to talk to the clinician and ask them, maybe we should get a CT, see how they feel about it. Because a lot of times this is also, if it's a big effusion in the setting of trauma, there's something else there that you're just not seeing. And maybe a hairline crack through the tibial plateau or through one of the femoral condyles or an impaction injury. This one was just a posterior lip of the tibia that, I really can't see. It's back here. Excuse me. Okay, when we get to the pelvis, there are a number of different injuries that we have. This would be an anterior compression injury. You kind of split the anterior sacroiliac joints bilaterally, you have diastasis there. If you see the symphysis pubis more than 2 centimeters, the patient's probably bleeding to death. And this person needs to be bound up. They need to be wrapped together with this mechanism to stop the bleeding. Angiography, if you need it, comes after, but first they got to be bound together. And so talk to the emergency docs and say, we got a very wide symphysis pubis, get ortho down here to put a binder on right away. A lot of fractures, you don't see the fracture line. All you see are buckling. Classic is the torus fracture in the kid's radius, but also the sacrum. Look at these arcuate lines. This is a buccal fracture. This should mimic this, a nice smooth curve. And that's a lateral compression injury of the sacrum. This is one of the mechanisms for a very severe lateral compression injury. This gives you what's called the windswept pelvis. You get run over, you get a lateral compression on one side, then the tire drops into the pelvis and opens up the opposite side. So you get a lateral compression on one side, and then you get an anterior compression or a shearing injury on the other side, opening it up. And so it looks like the 2 wings of the pelvis have moved over as if the wind had blown them. That's why it's called the windswept pelvis. Oops, excuse me. So here's a compression injury. Here, it disrupted arcuate lines with overlapping. Now, and here's a CT scan showing, the fracture. Another mechanism are vertical shears, and so and these are high hemorrhage incidents. You want to look at the relative position here. Obviously, this is not parallel with that. That's a vertical shear injury, and that's a really serious bleeding injury. When you talk about acetabular fractures, there's a couple big categories, but one of them are the transverse versus column fractures. Transverse fractures separate the wing from the ring. So they divide the acetabulum into a top and a bottom. The column fractures separate the acetabulum into a front and a back half. So that's the gross difference between them. And there are more details in your syllabus about it, but usually the transverse fractures on a CT scan go from front to back through the acetabulum. The column fractures will disrupt the iliopectineal line, and they will go from right to left. If it's an anterior column fracture, they'll go from right to left, dividing the front from the back. So that's kind of a gross simplification. When you're looking for fractures, when you're looking at fractures or trauma, pay special attention to the possibility that it's a pathologic fracture, especially if it's like the lesser trochanter. This is a common site for metastatic disease, or it's a high association with a pathologic fracture. And you can see the eaten away bone here. When you see a fracture here, you should find out if the patient's on bisphosphonates, and you should look at the other femur, always. It's often bilateral. The other femur may only have this little tiny bump. That's all you'll see, but that's going to break too. So when you see a fracture in this location, and there's no good mechanism for it, they just fell, rule out broken hip. They weren't hit by anything. They find out about bisphosphonate, and then if they have that, look at the contralateral femur for that little bump. There it is. That's an impending fracture. It's an insufficiency fracture. This is what it looks like on MR. Not very impressive, except here you can see the line and a little bit of edema on it. This will break eventually.